Hello, Ainagul.
Hi, nice to meet you. How are you?
Nice to meet you.
You are Ula. Yeah.
Yes, I'm Ula. Yeah.
I'm happy to see you, Ula.
Yeah, me too. Me too. Yeah. So let us try the sharing of your screen if you want.
Yeah, okay.
Wait a moment. I think I need to make you. Um, Can you do you see whether you can oh yeah, here.
You organize you organizer and you
Yes,
yeah, okay.
yeah.
Let me okay, I try to
So there should be some option to share.
yeah. Okay. Now I try to open my presentation. Yeah, and then I try to share. I don't know where is my no, this is it's not.
Do you see the share option?
Yes, I see.
Okay, yeah.
Okay. I don't know how I can open my presentation. Okay, I try to find not Chrome. I have to no, it's not. Ula, can you demonstrate?
I can also open it if you prefer that.
Yes, I think it will be.
It will be better. Okay.
Yeah, it will be better.
Hi.
Hello. Okay, so
Hello, everyone.
hello. So I will share the screen. Is it visible for you?
Yeah.
Okay, so then
Ula,
yes?
Ula, it's visible for me too, but I think if we wanted to save some time, maybe we will start with my second presentation.
Oh,
What
and
do you
what is
think?
your second presentation?
Yeah,
We
please
don't
open
need to
second.
we don't need to save time or something.
Oh,
Is this so which presentation do you want me to share?
I think the second presentation will be good because it's more informative for Central Asia. But I
Is it
sent
is
this
it
presentation to you and to all other participants just for information because
oh,
they should know
okay,
what is the ICAP.
right.
But in the beginning, my second presentation, I will like provide very short information about ICAP.
Is good. Then if you want me to share the second presentation,
Yes,
you
yeah.
would need to send it to me.
You have already?
I don't think I have this one, what I just opened.
No, you have another presentation too.
Okay, I think you sent me just one presentation, so therefore
No.
I don't know what the second one is.
Oh,
So, okay, I'm going to have a look at, so I received yesterday, I received one presentation. So
uh,
if you want to have another one, you need to send it to me. Or you can also share it from your computer, if that's easier. I think we need a moment to check. Ainagul, are you with us?
I think
Larissa, do
she's
you?
frozen. Yes, I can hear you.
Yeah. But I think Ainagul is frozen, right? She can probably not hear us. Yeah. Okay. She's going out.
I will get some water and
Yes, it's fine. Shahnoza, how was your travel back? Hello, Ainagul.
hi, Ula. Did you
Hi.
receive my presentation?
Yes,
Thank
I
you.
received it. Okay, I will download it. Just a
Thank you.
moment.
I sent you both, but I don't know why you didn't receive second one yesterday.
Yeah, maybe sometimes it's so that there's yeah, I don't know whether
something happens.
so. Oop. So, hi Isolu, nice to see you.
Hi, everyone.
So I think we need to tell others about the link. Oi, oi, oi. Mm-hmm. We are waiting a little bit for others to join. Hello. Hello, Aijan. Good to see you. So, can everyone see the presentation? Okay,
Yes.
yeah, shall we start or shall we wait for another moment?
Let's start.
Let us
If you
start.
don't
Yeah.
mind. Yes.
Hello, everybody. Welcome to the Solid Talk. And this is the last one before our summer break. And I'm especially happy to be with you today and introduce our speaker, Ainagul. Ainagul will give us a presentation about strengthening the capacity of Central Asia and Eastern Europe to implement sustainable and effective HIV prevention programs in the framework of PEPFAR. I think this is very relevant for the solid topic as we are focusing on infectious diseases as well, and especially HIV and AIDS. Dear Ainagul, please, the floor is yours.
Yeah, thank you very much. I am really happy. It's my pleasure to present to you ICAP's activities in Central Asia on implementing sustained and effective HIV/AIDS prevention, care, treatment, and also under the PEPFAR frame, we have health security program. And it's my pleasure to explain you what is the key results, achievements we have because we work in Central Asia over 15 years, and in general, ICAP, it's international non-governmental organizations under the Mailman Public School at Columbia University. Next slide, please. Yeah, in ICAP had worked almost in 40 countries in worldwide, mostly projects ICAP implemented in the Africa region, but during the last 15 years, ICAP started their work here in Central Asia. And since 2024, ICAP implemented several projects in Kazakhstan, Kyrgyzstan, Tajikistan, started implemented project in Uzbekistan, Turkmenistan, Azerbaijan, Moldova, Georgia, Ukraine, and Armenia. Next slide, please. And today I wanted to present you key success and challenges during implementation PEPFAR programs from 2019 till the 2024. Next slide, please. This presentation was prepared by Deputy Strategic Information of our regional director, and I used the his main slides for presenting to you. Since during till the 2024, ICAP implemented two big active projects. First, it's a technical assistance to Central Asian national HIV programs to achieve and sustain HIV epidemic control. This program supported by PEPFAR through CDC and implemented at 3 countries, Kazakhstan, Kyrgyzstan, and Tajikistan. And the second active project was enhancing global health security, strengthening public health surveillance system and the preparedness globally. This project also supported by CDC and implemented in the same countries, which I demonstrated in my first slides. Next one, please. In the first part of my presentation, I will little bit stop it in global health security programs. It was first program, regional Eastern Europe, South Caucasus field epidemiology training program. And during the 10 months, we conducted on-job training program for public health professionals and veterinarians, aimed to build local capacities to evaluate and strengthening public health surveillance system, investigate outbreaks, inform control measures, and conduct field studies to address public health issues of concern. And the third cohort includes 16 residents from Armenia, Moldova, and Ukraine. In the next slide, you can see another program implemented under the global health security program called EPITEC. This program included the data modernization for field epidemiologists, and program aimed to empower graduated of the FITR, field epidemiologist training program, intermediate and advanced levels to use digital tools to enhance their work, include researches, Coca-Cola, Quiz, Power BI, Microsoft Power Query, Advanced Excel, and Go Data. Next, in the next slides, you can see the participants of regional public health emergency management training program. During the 8 months, all these participants participated on the on-job training program for public health professionals. Then program aimed to strengthening the public health emergency management workforce for the Eastern Europe region, enhancing national and regional capacities to respond rapidly and effectively to public health emergencies. The curriculum includes a blend of workshops, online mentorship, educational courses, and networking opportunities. The first cohort includes 16 fellows from 8 countries. In the next slide, also you have seen regional community of practice on influenza like illness, severe acute respiratory surveillance infections. This program implemented to improve the quality analysis, improve the quality analysis and use the ELI-SARI surveillance data. This initiative includes particularly whole country of Central Asia, Moldova, Ukraine, and some of the workshops, webinars participated our colleagues from Georgia. It encompasses annual in-person meeting, quarterly virtual meeting, and country-specific workshop and meetings. Next one, please. Other global health security initiatives implemented in Central Asia countries, it's an infection prevention and control training program implemented mostly in Kazakhstan and Georgia, support for the development of national syndromic surveillance system, support for antimicrobial resistance response in Ukraine, Armenia, and Georgia, and also ICAP support for the national development of national hepatitis register in Kyrgyzstan. Next slide, please. Then I wanted to, it was some activities on global health security program, and now I wanted to provide you information about the HIV activities in Central Asia implemented by ICAP, and mostly I try to demonstrate my slides for Kyrgyzstan, but some of them also have information about the situation in Kazakhstan and Tajikistan. You know that regarding UNAIDS program documents, progress of HIV response we measure through 95 targets. And the PFAR also supported all UNAIDS initiatives. And here in the slides, you can see the progress which we receive, which we have over the 5 years. It's changes mostly in Kyrgyzstan. For example, in the slide, in the left side of slide, you can see that data for the September 30, 2019, and yellow one, it's data for September 30, 2024. In Kyrgyzstan, ICAP's involved in a HIV program around the 20 facilities in Bishkek city, Osh city, Chuy, and Osh Oblast. And ICAP working with medical facilities and covered around 77% of national estimated number of people living with HIV. And if you can compare the data, you see that Kyrgyzstan achieved really good results on RT treatment and suppressed viral load. Also, you can see the less number of and the percent of people who live with HIV and who know their status. And we have several causes for this, because we have a lot of people who lost, and we implemented several activities to follow up and to find the people who detected sometime, but then was lost, and also like some of them died, some of them lived out of country. I have slide on that, and I will demonstrate a little bit later. In the next slide, you can see You can see 95, 95, 95 targets by subnational units as of September 30, 2024. And here you can see Kazakhstan, Kyrgyzstan, and Tajikistan late sites supported by ICAP, and you can see the results by units. First column it's first 95, and you can see that no any countries who really achieve estimated number of detected PLHIVs. Second 95 looks better, and you can see that especially like Osh city, Osh Oblast, Dushanbe city, Sokt Oblast, and some rayons around Dushanbe city achieve 96, 99% of PLHIV on IRT among those who know their HIV positive status. And we're proud of our medical workers who work with our project. We achieve really good results on third UNAIDS 95 targets, and you can see that around from 92 till 99% of PLHIV with viral load suppression among those who know who are on IRT and have been tested for viral load. Next one. Here you graphically can see, for example, where we were and what is the results we achieve. You can see that green, not green, red, it was in September 30, 2019, and blue or blue one, the situation in September 2024. And we have progress, particularly in all our sites supported by our project. Next one, please. This slide we demonstrate for understanding epidemic control can happen if number of new HIV infection is lower than the number of deaths among HIV infected patients for any reason, and both of these values are low and decreasing over time. Here the example of Botswana, and you can see that number of new cases and deaths in one place, in one point. Situations in our countries looks little bit different. In the next slide, you can see that for example, in Bishkek city, new infections grow on. You see, new deaths also grow on. That means that we don't have epidemic control on HIV in Bishkek city. In Chuy Oblast, the picture looks a little bit better. You see that new cases grow down, and deaths also go down, and we hope that in Chuy Oblast the government of Kyrgyz Republic can control the epidemic. Osh city also situation not really good because new infection grow up, and but new deaths go down. That it's looks like not a good situation, and our government should spend more attention for situation and try to do everything for epidemic control and epidemic control of HIV. Next one, please. Key activities to improve HIV prevention. We conducted trainings, regular mentoring support for providers. Providers, it's 20 medical workers from 20 facilities included in our project. And we do it for ensure quality HIV prevention, counseling, including counseling on PrEP, initiation and continuation, PrEP in whole 3 countries. A temporary support to community-based PrEP initiation in Kyrgyzstan. We try to build really good cooperation between medical workers and non-governmental organizations, and we collected some of examples, experience which we use for continuation our joint work with non-governmental organization. Also support implement electronic PrEP in Kyrgyzstan and Tajikistan. Also, we try to distribute the information about PrEP and its availability among key population through the HIV test platform and also through communication with non-governmental organizations. And in the right side of my slide, you can see that number of people who started PrEP in Kyrgyzstan and Tajikistan grow up from fiscal year 21 to fiscal year 22. And different color demonstrated the type of groups. For example, people who inject drugs, green one is transgender people, discordant partners, men who have sex with men, it's a yellow color here, and the female sex workers, red one. In the next slide, you can see cumulative PrEP new and PrEP continue in Kyrgyzstan and Tajikistan. Also, you can see that the number is grow on, and I hope that all activities will be continued, and PrEP will be one of the really good prevention for HIV in our countries. Next one, please. In the next slides, you can see key activities to improve HIV testing. We try to implement new approaches using the existing approaches too, and one of the new approaches was online HIV self-test giveaway services. We implement social network-based peer-driven incentivized recruitment of clients for testing, use of self-test to facilitate index partner testing, online and offline anonymous partner notification option with tell you partner. It's like program looks called Tell You Partner. Routine and regular mentoring support and training to providers to ensure quality counseling. Next one. In the next slide, you see that more than around the 15,000 HIV self-test kits were delivered in 12 cities across 3 countries from February 18, 2022 to September 30, 2024. And we provided enveloper with information educational materials, and the people have access for ordering self-test kits in a website, which you can see in a low part of this slide. Next one. I think it's one of our achievements that the middle age of people who ordered self-test kits was 26 years old. This age people don't visit medical facilities, and most of them not member of non-governmental organizations, but can have risky behavior. In this slide, you can see, go back, Ula. This slide's about facility-based social network-based HIV testing strategy. We call this SNS. We try to expand access to voluntary HIV testing services for all people from high HIV prevalence group. And during the during the little bit more than 1 year, 753 people tested for HIV through this approach. 23 people was detected with HIV. 23 of them, particularly whole 100% initiated ART, and 233 people started PrEP. In the next slide, you can see index testing data, and it's this data different like from countries, but index testing, it's one of the standard approaches which we use it for detecting new positive PLHIVs. Next slide, please. We use dashboards for analysis. We're sharing these dashboards with providers and using these dashboards for the planning our activities to using new approaches and achieving the good results. If we discuss about the key activities to improve antiretroviral therapy coverage, we providing intensive mentoring support to review data, ensure prompt ART initiation for all PLHIV, including video counseling, ART initiation in the remote areas in East Kazakhstan. Active patient tracing effort in case of a missed visit using the algorithm. We develop the clinical guidance, algorithms, approaches, methodologies, and training our medical workers to use them for achieving the better results. Also, we implemented the automated pre-appointment reminder for clinical visits and ARV pickups. Also, ICAP using financial incentives based on proportion of newly diagnosed individuals initiated on ART within the first 7 days from the detecting from the diagnosis. Next slide, please. And here also it's a dashboard, and it demonstrates how we try to analyze the data and use this data for future planning and for improving the providers' work. Next one. This dashboard also about the people newly initiated RT, and also we try to work with people who was lost, and we implemented several activities to find the people who was early detected and try to initiate it anti-ART. Next one. Losses of people on ART also, it's one of the dashboards which we use for our work, and the providers also use this data. And losses of people on ART, you can see from October 2019 to September 2024, died 562, refused ART 168, interrupt treatment so 361. I try to explain you that we always try to analyze our work and planning our activities. Next one, please. Key activities to improve IRT outcomes. We promote and improve understanding of equal you among providers and the PLHIV community. Also, we implement nurse-led home-based structured IRT adherence support. Because the PLHIV sometimes really tight on taking treatment, medications, and adherence support. One of the main activities we try to implement among the PLHIV. Automated SMS-based notification with viral load and viral load test results. Telegram-based online services for counseling and peer-to-peer adherence support. That means that our medical workers, providers, always try to work with non-governmental organizations for adherence support for loss to follow-up activities. Support multi-month dose and home delivery of ARV. Also, we provide intensive mentoring support to improve advanced HIV disease management. Next slide. In the next slide, also, you can see viral load testing and suppression. I already demonstrate this information in my other slides. We can go ahead. You know, the CDC always requested some information about our results, and we have special MER indicators, and we provide our reports based on these MER indicators. I think it's not necessary to stop on that, but I wanted to say you that we always try to be on one page with our providers, provide them information about their achievements, and use the data for planning their activities. This is you can you can see additional information if you use this. And in the next slide, I wanted to say thank you in several languages. It is success and challenges. Success, I think this, you can read this one, and the challenges, I want to stop on that because it's one of the barriers, big barriers to achieve good results. And one of them, high levels of stigma and discrimination among the general population, insufficient staffing and turnover of medical personnel, punitive law and practice, especially in Tajikistan and Kyrgyzstan, suboptimal quality of harm reduction program, no long-acting PrEP, no TLD, it's antiretroviral medication till June 2024 in Kazakhstan, periodic issue with timely supply of ARV in Kazakhstan and viral load tests in Tajikistan. COVID pandemic also was one of the barriers, and we lost a lot of our patients. And one of the really big challenges is sustainability of intervention approaches and models which implemented by ICAP in Kyrgyz Republic, Tajikistan, and Kazakhstan also. The next slide, thank you very much, and thank you very much in all languages which work with ICAP in Central Asia, Caucasus, and Ukraine and Moldova. Thank you for your attention.
Thank you. Thank you. And Rahmat.
Not at all.
Okay, thank you so much. So I will close the presentation. We can come back to it if we want to look something up. Thank you so much, Ainagul, for this really a very informative presentation on your work. And I think it was very good to see also the precise data to actually understand what your organization is doing and what it has achieved. Now would like to give the floor to Larissa Steimle of Technische Hochschule Nürnberg. And Larissa will start the discussion by giving some comments to your presentation. Thank you.
Yes,
So
thank
Larissa,
you,
the
Ulla.
floor is yours. Mhm.
Yeah, and thank you so much for this really wonderful presentation. What I found most interesting was ICAP's ability to combine research or data and specific interventions, which is really great. And I don't think that there are many organizations that do both. And as we are all researchers, I was wondering if you could elaborate a bit more on the data collection. So how did you get this great amount of data?
Yeah, thank you, Larissa, for your questions. You see, during the 15 years which ICAP had worked in Central Asia, we implemented several digital programs. First program which we implemented, it was electronic HIV case management. That means that all patients which firstly detected in Kyrgyz Republic, Kazakhstan and Tajikistan included in the system. And this electronic case management, HIV case management system have three parts. First, it's laboratory part, second, epidemiology part, and the third part is the treatment part. And using this register, this system, we have data, and also we are working on improving the quality of data. We conducted a lot of trainings. We try to, sometimes we have the quality assessment, visit to our medical facilities. We work with our providers, and all data for the dashboards we incorporate. We have using this electronic HIV case management system. Next one, it's HIV hepatitis register, also methadone substitution program register. We implement the PrEP register. We implement, it's all electronic systems. And it's like first time it's really difficult to providers work with this system, but then this system allow our medical providers use data for analysis and for planning their future work. Also, this data used for policymakers when we try to advocate, promote some of activities, implement new approaches, and it's happening in our country.
Very interesting, thank you. And I was also wondering, because our project focuses on people who use drugs, this is one focus, if you could tell a bit more about this specific group, because I can imagine, it might be quite challenging to get data on this group, at least in the beginning, as long as they are not diagnosed. Maybe, yeah, you could elaborate a bit more about this group.
We participate on conducting several BBS, behavioral researchers, and PWID, people who use injecting drugs, always include in the BBS surveys. And also in our country, I think it's a really good point. We have a lot of non-governmental organizations who are working with PWID. And also, we have a methadone substitution program in Kyrgyz Republic, in particular in big cities, in a penitentiary system, and also all providers of methadone substitution therapy use the register, and all PWID who included in this program included in this system too, and we also can analyze and can work with the data. And unfortunately, we tried to conduct survey on estimated number of pivot, because last one were conducted many years ago, and in 2004 by UNODC, and then we don't have other like surveys, researchers on estimated number of pivot. That's why we like using the old data, and sometimes it's really challenging to measure the results, because if we compare, for example, results which were like 25 years ago and now, I think the data is really different.
Mhm. Yeah, thank you so much. Maybe there are questions from the others as well.
You can raise your hands, or you can actually put your question in the chat. Both is possible.
If not, I have another one.
Can I say?
Yes, please go ahead,
Dear
Shahnoza.
colleagues, how are you? Glad to see all of you. And dear Ainagul, I'm glad to see you. Let me introduce myself. I am Nurgul from Bishkek State University. We work together with Aysel, Aysulu, and Ula, Larissa. It is our big project, Solid. Maybe you know, about our work. I have just joined, but I have already heard about your work. Thank you for everything you do and for your dedication to supporting vulnerable groups. And I would like to say that together with my colleagues, we conduct research in 3 areas: social work with HIV people, with prisoners, and with addicted people. And in this area, we try learn more, try to be involved in different researches, and also we would be very interested if any opportunities for research collaboration with your organization. If there is a possibility to work together in the future, we would be delighted. Thank you very much for your presentation and for your work. And nice to see you, Ainagul.
Yeah, thank you, Nurgul. Thank you, Nurgul, for your comments, for your readiness to work with our organizations. But unfortunately, our organization in Kyrgyzstan closed in December 2025 by the Trump administration, because our project was stopped early. Then we should work. But I know a lot of people among governmental, non-governmental organizations, among clients of several programs. And if you need my support as an expert, and you want to use my communications, my experience, expertise, I am ready to work with you, because I know that social work, social support for PLHIV, for another vulnerable group is very important, because it's one of the factors which support adherence, which support continuation of treatment, changing behavior, socialization. That's why I am ready to help you. Thank you
very much. Thank you. Thank you.
Thank you very much. Ainagul, this is also very sad that your organization has lost its funding. So we see this, of course, in many countries. And it's good to be aware of this. Yeah. Are there more questions?
I think there is one in the chat.
Yeah. Can you, so shall I read the question in the chat? It's a question from Gulazia from Kazakhstan. And I'm going to read it because I assume that Gulazia has not a good microphone at this moment. Otherwise, Gulazia, you can also say something. Okay, so I'm going to read it. Thank you for your presentation. I have a question, says Gulazia. You mentioned that there is an electronic registry for HIV and viral hepatitis. Have there been any studies being conducted using data from this registry on HIV and hepatitis co-infection?
Yes.
If so,
yes.
could you briefly share the main findings?
I can right now share the findings because I don't prepare presentation, not include this. But if you want, I can send maybe by different emails this data because it's very important. You know, especially PWIT, most of them have hepatitis. Yeah, and we try to link all these people to the hepatitis treatment. We have this register, we have data. Also, we have data on TB, tuberculosis. If you're interested, I also can share this information. Also, we have data how many PWID have HIV, how many PL HIV have experience on using drugs, something like this. And please send me all your requests and I can share the data.
Yeah, thank you very much, Ainagul. I would also like to ask a question. So you were showing us the progress that has made in reaching the 95, 95, 95 goals of UNAIDS. And what could be clearly seen in your presentation was that it's most difficult to achieve the first goal, like to achieve that 95% of all people know about their status. So that people know about their status, that they are HIV positive. Can you explain to us why it is especially so difficult to achieve this component?
Dear colleagues, Ula, you know that estimated number selected by the statistical data from researchers, from something like this, you know, and it's sometimes it's not clear number, but we try to achieve this because during the finding the estimated number, we have special methodology. Mostly it's methodology provided by UNAIDS, and we try to find these people, you know. But currently, situation in our countries different than many years ago. And now, for example, we don't have pivots which we can achieve, which we can reach, because mostly now the narco system delivery, the drugs system also changed. The people who use drug now more close than many years ago. Also, we can achieve the first 95 because we, you know, we have a big stigma and discrimination, and the people who have not good behavior afraid go to the medical facilities and know their HIV status. That's why we try to use the new approaches like self-testing, like SNS, like other approaches, because we try to avoid the physical contacts with medical workers and provide more opportunities for people anonymously tested for HIV. But this approach works, but not really good as we expected. That's why it's a main problem not for our country. It's a problem for particularly for many countries in the world.
Yes, I know. It's a general issue. Like this, prevention is most difficult, and treatment is a little bit easier because then people have an interest to be included in treatment, right?
Yeah, yeah. And I think it's one of the achievements of UNAIDS and other governments. It's opportunity to have antiretroviral treatment. It's TLD. It's a really big progress on HIV treatment.
Yeah, thank you. Are there more questions? If not, I have a second one. So you also told us about PrEP and the introduction of PrEP in Kyrgyzstan. And here I would like to know, it's rather to better understand your presentation. So you mentioned the different groups of people who can receive PrEP, and one group was discordant partners. And I was wondering if there's a couple and one partner is HIV positive and receives RRT, and the virus load is suppressed, fully suppressed, is there then a need for the second partner to actually get PrEP? Is it so that in any case the partner receives PrEP, or only if there are difficulties with RRT? Thank you.
Yes, you're right, Ula. We have discordant people, and when it's like newly detected HIV cases and newly started IRT, we recommended PrEP for their partners. When we have viral load suppression, we provide them information. Are you sure that your partner take RT treatment very accurate? Because if PLHIV don't take pills on time, sometimes we have high level of viral. Yeah. That's why we recommended use PrEP for all discordant partners. But sometimes I know that our discordant partners have rest time, because when people always take medication pills, they a little bit tired. That's why we thought, if you're sure that everything is good, your partner take pills on time, everything is nice, you can have it's for your option. But we recommended use PrEP all time.
I see. Okay, I see. More questions. We also have some of our partners working in the field of HIV/AIDS. Maybe you would like to know something specifically from Ainagul?
I also have one question, or one more question. I'm very interested in prisons, and I was wondering, could you say something about how is the data collection going in prisons in Central Asia?
I don't know what happened in prison in Kazakhstan and Tajikistan, but in Kyrgyzstan, in prisons, we also implement the electronic HIV case management. Methadone substitution therapy register also work in prison. Hepatitis register also work in prison, but I don't know about the accuracy of data, because ICAP never work with prison directly. we did it through our providers. And right now, I don't have like correct information how the data work in prison, because I know that last 2 years, the senior management of prison became a little bit close, and no all organizations have access to prison and prisoners. What I can say.
Yeah, thank you. Interesting.
And Ainagul, you mentioned it several times, the digital case management. Maybe you can explain it a little bit more, what you mean by digital case management and who's actually involved in this case management. Is it the HIV/AIDS centers, NGOs? I mean, who has access to the case management? Who's collaborating?
When I said case management, it means the process. One people who live with HIV, and it's one case. And medical providers try to work with each case, because some of cases is challenging, some cases easy, because it's people who very accuracy take ART, who completely understand the situation. But some cases is very challenging because it's, for example, PWID or homeless people, you know. Case management means that we have sustainable patients. It's a like a group of cases, and work with these people a little bit easy than with people PWID, not the patients with bad behavior, homeless people. That's why we told this case management. We work with each case and we try to prevent interruption, prevent losses, prevent death, prevent the bad healthy conditions, etc. Case management means that we try to individually work with each patient and provide them services which they need.
Thank you.
In the case management involve physicians, doctors, involve nurses who like support adherence support, involve non-governmental organizations, especially for PWID, for men who have sex with men, for female sex workers, etc.
Thank you. Yeah.
Thank you. Dear Ainagul, I have one small request. At the moment, our team is working on some articles, and one of article is about social and psychological work in penitentiary system in Central Asia. Maybe if you know some publications, some information, maybe reports about the social and psychological work in prison system in Central Asia, maybe could you share them, please, if you have, if you know about some reports, maybe recent. We need recent information about it, and also about HIV. We need some new information. Maybe we might not know about it. It would be grateful if you could share them.
Okay, we have library. We don't have like special research on social work, on the social support, but mostly all researches surveys include some part of social work. And I think the Global Fund, maybe you need to prepare a special letter and request some information. Global Fund have all reports from governmental, non-governmental organization on implementing activities, researches, surveys in your areas, and maybe it will be helpful to reach these reports and use these reports for your article, for your work too.
Thank you. Thank you. Thank you, Ainagul.
Okay, thank you all for joining today's Solid Talk. Ainagul, if you are happy with this, I could share your email address. Would that be okay?
Yeah.
Okay, so I will forward the email address, then you can get in contact with each other. So thanks a lot, Ainagul, for your presentation and also for answering all of our questions. And thanks a lot, Larissa, for serving as a discussion today. And yeah, so this was our last Solid Talk before the summer break. I think it is a well-deserved summer break. Many of us are going on vacation, spending some time off. We will come back together in September. And I'm also going to send you an email with questions about what topics you would like to have covered in the Solid Talk series for next year. So you will also get an email from me, and you can suggest topics and speakers. And Ainagul, if you would like, we would be really happy if you also would like to join our discussions. So so that we can see you again in the future. And thanks again very much for your talk today.
Thank you very much. Thank you for your attention, for your question. I wish you all the best and have a nice vacation. Please keep energy, keep everything is best to continue your work, your great work. Great job. Thank you very much.
Thank you. Okay.
Thank you. Bye.
Bye-bye.
Thank you.
Thank you. Bye-bye.
Bye-bye. Bye-bye, Nurgul. Bye-bye, Asel.
Bye-bye, Larissa.